Hello, my name is Edwin Su, and I am a hip and knee surgeon on the Adult Reconstruction and Joint Replacement Service at Hospital for Special Surgery. Today, I am joined by two of my colleagues on the service and two of the brightest young minds in joint replacement surgery, Dr. Peter Sculco and Dr. Alex McLawhorn. I'm really excited to talk to them and get their opinions on an interesting topic, the management of hip arthritis in the younger active patient. It's a subject that can pose some challenges for patients and surgeons, mostly because these patients are still very functional on a daily basis, so it makes it difficult for them to decide when to seek treatment. We also know that this is one of the fastest growing segments of patients who need hip joint replacement surgery, the under 60-year-old age group. Statistics have shown that in the United States between 2000 and 2010, the number of total hip replacements performed in patients between the ages of 45 to 54 increased by over 200%. This is also a topic that is particularly relevant during the lockdown phase of the coronavirus pandemic, because I think patients have changed their usual activity regimen, and this may have affected their symptoms. They also have more time to ruminate about their condition and wonder whether or not they are really ready to have surgery if that may be their case. So Alex and Peter, I'm excited to get your opinion about this. I'd like to first ask your thoughts on how changes in activity patterns, for example, not regularly exercising and working from home, may be affecting the young active patient with hip arthritis.
Sure, I'm happy to field that first. I think in terms of my patients, I've had patients go both directions in terms of how they're doing with their hip and knee while they've been working from home and changing their activity levels. I think some people have been more sedentary and perhaps their joints haven't been bothering them as much. But on the other hand, I've had lots of patients, probably an equal number, who have become more active, have used this opportunity to start to work out more in their homes, perhaps buy some exercise equipment that they didn't have before and make those investments. And then they've started to have more symptoms in their hip and knee and have had deterioration in the symptoms of their joints. So I think we've seen it go, at least I've seen it go both ways.
Peter, what do you think about that?
Yeah, absolutely. I think some patients, they're staying more at home, right now. So that is some enforced activity modification. They're not commuting as much. Sometimes, stair climbing, taking the subway can aggravate hip or knee conditions. And currently that's not an issue. So similar to what Alex said, though, is that some patients have taken this opportunity to really pick up their home exercise routine, and they've gotten, let's say, a home exercise bike, or they're doing things online, they're doing fitness classes, and that has led to some mild aggravation of some of their symptoms. They try to push themselves more with this newfound time. I think, it goes both ways, really.
Right. And I myself have found in that younger active patient, sometimes they need regular activity to help their joint lubrication, the muscles around their joint function. So actually they tend to feel better when they're being more active. You would think the opposite, but actually their joints can feel improvement with activity. So this phase has really kind of affected that as well.
I'll just say one thing. A lot of people, sitting for hours at a time, like you're saying, and then a common complaint is the first time they get up after sitting, they've got that initial stiffness, takes them time to get moving. And actually a lot of people are just walking circles in their living room to kind of lubricate, like you're saying, in between sitting at their desk. So absolutely.
Yeah, definitely. So Alex, what sorts of activities are you advocating for your patients who are suffering from hip arthritis during this working from home phase and not being able to do their usual activity regimen?
Yeah, I think in terms of just overall activities that we sort of recommend for hip and knee arthritis or hip and knee conditions, it's always been a regimen of sort of low impact exercise, low impact aerobic exercise, some gentle stretching, and then strengthening the muscles around the affected joint. I don't think those recommendations have really changed in terms of the work from home setting compared to prior to this sort of pandemic situation. But I think that patients have to be more independent maybe than they used to. We used to send people to physical therapy and have the therapist guide them through some of that process. There are some online resources and virtual resources for patients that want to do physical therapy in their home, but I think patients are more self-reliant on those sorts of exercises than perhaps they've been in the past.
Peter, maybe you could tell me what your
Yeah.
typical patient with hip arthritis would be suffering from in terms of their symptoms.
Sure, sure. I think the first thing is going to be pain, right? So pain, usually localized in the groin, is probably the most common, complaint that's associated with hip arthritis, aggravated by things like going up the stairs, putting on shoes and socks. So that's going to be a very common situation. So groin pain aggravated with certain high impact activities or activities that require a lot of range of motion of your hip. From there, it's going to be limitations in function. So some people can do well around the house, but they start to push themselves, walking faster, trying to do more higher level activity and sport. And that's going to basically, their hip can be fine the majority of the day. And then they try to do some sporting activity, and that's going to really trigger a pain response. And that can go on for some period of time. So decreased functional activity is also very common. Sometimes it's just stiffness. So it's not necessarily painful, but their hip just doesn't move the way they wish. And they just have this persistent feeling of stiffness without frank pain. And oftentimes that's also a pretty common symptom.
Alex, can you tell us about some of the non-surgical treatments that you recommend for young patients with hip arthritis?
Sure. Yeah, I think, as we talked about, the mainstays being physical therapy and low impact exercise, strengthening the core, strengthening the muscles around the hip. We know that's has the highest level of evidence in terms of helping patients with their hip condition. Next on that list would be things like anti-inflammatory medications, and whether that's over-the-counter medications like Advil or Aleve, or those are prescription medications that you would get from someone like us. Those are obviously very beneficial. And then next would be weight management. So we know that patients that are carrying around a little bit of excess weight, that tends to aggravate a hip condition. About 2 to 3 times your body weight is put on the hip joint with every step. And so every pound you can remove is going to eliminate that pressure off that joint. So those are the 3 main things that I recommend for patients right out of the gate when they start to have hip or knee conditions, hip conditions in particular. Sort of the second line for me would be a more invasive treatment like an injection or so. But I usually want to try those other non-invasive measures first before we go down that road.
Peter, what's your opinion about injections for hip arthritis? And can you tell us a little bit about the different types of injections?
Sure, sure. So basically the most common injection is an intra-articular injection of cortisone and a short-acting medication like lidocaine, which basically numbs the hip for a short period of time, and then the cortisone has a more longer acting effect on inflammation in the hip joint. I use them sparingly. I think that they're oftentimes used sometimes for diagnosis when you have a low back condition, as well as having a hip condition. You're trying to figure out which one is really the pain generator. So you can use that to really confirm that the hip is the source of the problem. Other times I use it as someone who, they have a wedding, they have something planned where they really need pain relief for 6 weeks, maybe out to 3 months, and they can't have a surgery during that time period. So you use it to kind of carry them over. Using it as a long-term treatment, I like to try to avoid, because there are some potential downsides to doing cortisone injections in the hip that we don't fully understand. But I think that there are some cases where you can potentially see some progression of arthritis. So I don't want to use it really as a long-term management solution. Other things like hyaluronic acid, gel injections, that's really not currently approved for use. It's approved for use in the knee, not the hip. PRP, stem cells, other injectables, the evidence is still out. I think that's an area of ongoing research, not covered by insurance, of course. So that's going to be something where maybe, has some unknown benefit, but I think the jury is still out on that.
Yeah, I totally agree with Peter on all those points. I think there's some people for whom they really get a big benefit, especially out of the first injection from a therapeutic standpoint with a cortisone injection into their hip. The natural history of those injections, at least in my practice, is that the first one works pretty well, and then the subsequent ones don't really provide much benefit. So, a one-time treatment can get someone through that special event or so, or if they're not ready to start thinking about an operative intervention or so, then that's a good bridge. I think the one thing we have to highlight for all our patients is that they do elect to have an injection, then that does necessarily delay a surgical intervention at least 3 months. We know that there's an association between timing of injection and infection after a hip replacement. So they have to be aware and informed of that ahead of time. So I think there's also a certain subset of patients that have really advanced arthritis and certain radiographic features that I would definitely not recommend an injection, because there can be specific complications related to the injection if they happen to have those signs on their x-ray.
Yeah, both of you have made excellent points. It sounds like both of you use injections pretty judiciously, really only if necessary. Really a good tool for a diagnostic purpose when there's symptoms kind of overlap between the hip and the back, and you really want to know what's emanating from the hip joint. I think that's a really useful aspect of injections. And Alex, you brought up the fact that after any joint injection, you really can't have surgery within 3 months of that injection because of the risk of joint infection. So moving on to the next question and the next level of treatment. So moving into the surgical arena, I think a lot of patients now, especially in this phase where they're working from home, they have more time on their hands, they're really wondering whether or not they should pursue surgery. And in your mind, Peter, what are the triggers and factors that would tell a patient that it's time for them to have surgery?
Sure. So I think Alex nicely outlined the conservative treatments, going through that algorithm of, physical therapy, weight loss, core strengthening, anti-inflammatories. And the question really is, when you try those interventions first, which we always try to do, what response do you have? So if your pain goes away, your function improves with those interventions, that's great. It's when those treatments fail that we have to look for other alternatives. So the things that I would look at, the 3 things we look at is pain sleeping, pain with activities of daily living, right? That's going to be the main driver, because no one wants to live in pain. Second thing is going to be function and the activities. And basically, it's activities that we can restore well after hip replacement. I think we're going to discuss that shortly. So if your passion in life is that you want to be able to, play doubles tennis, and all of a sudden, that's not possible for you because of your hip pain, you talk to someone who does hip replacement like us, and we can guide you as to the possibility of restoring that function to you, that activity to you, which hopefully leads to improvement of quality of life. So it's really pain, it's loss of function that you find unacceptable, because overall that's influencing you're basically satisfied with your current quality of life due to your hip condition.
Alex, you've done a lot of work on quality of life. Can you tell us a bit about the potential implications upon a patient's quality of life after this type of surgery? And is it different for younger patients versus older patients?
That's a great question. I'm going to sort of piggyback on what Dr. Sculco was saying in terms of when you elect to have a joint replacement, because I think that ultimately it's different for every single patient. That choice is personal. We as surgeons are here to help patients make that decision. We help guide that decision-making process. We, of course, take the patient's preference into consideration, and we have a lot of other tools that can help the decision-making process. An x-ray is the most simple tool that we have in terms of saying, yes, you have a really severely arthritic hip or so. But we have other tools that we've developed in terms of the questions that we ask patients, where you can have a better understanding of where they are in terms of their symptoms and where they are in terms of their quality of life and the dysfunction of their hip joint, to then better guide them on making the best decision for when to have surgery. So, so it really comes down to that decision-making process between the patient and their surgeon. And in terms of quality of life, because that's really what this is all about, most patients are going to choose to undergo a surgery when they've had a significant diminishment in their quality of life on a weekly basis or daily basis because of their hip joint, and they're ready to have surgery in order to improve that quality of life. We know that in terms of hip replacement surgery, that is the single best intervention that probably modern medicine has in terms of improving patients' quality of life. It is immensely successful, and it has a tremendous impact on measurements of quality of life. So it's a great tool at our disposal to help patients. In terms of younger patients and what this means, I think it's incredibly important because in terms of quality of life, it's not just about when you decide to pull the trigger. Age has a big factor in this. So what I like to say is that quality of life is a lot like a dollar. You'd rather have a dollar today than a dollar tomorrow, and quality of life is the exact same way. You'd rather have a quality life year, or a year lived in good quality of life now versus 10 years from now. So there are some folks out there that may think that there's a specific age under which you shouldn't have a joint replacement. And I think more and more we know and understand that that's not really true, that that's kind of an arbitrary cutoff, because we don't want patients suffering for many, many years with a hip condition when we can treat it effectively with a replacement and restore their quality of life and allow them to live those years, however long it might be, with a good quality of life.
That's a really excellent point. It's as you said, our paradigm is shifting towards quality of life now, rather than trying to put off the surgical intervention for as long as possible, which was kind of the older way of thinking. Peter, I'd like to get your opinion about the treatment, as we talked about, of hip arthritis in the younger active patient. What is it about these patients that makes it more challenging, and what are the considerations that you have to take into account?
Yeah, sure. Well, number one, you have to understand, why do they develop hip arthritis at an early age? So there's a number of different causes. So it could be hip dysplasia. Some people have mild undiagnosed hip dysplasia where the ball is not really covered by the acetabulum, and that can lead to early arthritis. It could be the other way, where the ball is actually too covered, called impingement. And a lot of people have early arthritis secondary to that. There could be pediatric hip conditions where they had a trauma, surgery, infection. So first of all, you have to really understand, is it just early arthritis, or is it from some other pathology that we need to know about, and then we can specifically address? So once you confirm the diagnosis, I think some specific considerations are, obviously, this is a very active group of patients. So I think that we really have to be meticulous with the surgery in terms of, obviously maintaining, the abductor muscles, which are key muscle groups, careful restoration of hip biomechanics. And we can talk about how to achieve that to really make the hip feel, I think, as normal as possible, and really understand that they're going to be doing a lot of activities which have maybe more range of motion requirements than older patients. So understanding, maybe we can talk about that, the dynamics of how their pelvis moves, where to put these parts in so you have optimal range of motion and optimal stability. And then also, of course, things like longevity of our implants, so they can last for several decades.
Yeah, so you brought up some great points about the function of the joint and the longevity of the joint in these younger active patients. Alex, maybe you could talk about what are some of the surgical options for the treatment of end-stage arthritis in the younger active patient?
Right, I think it really comes down to either a total hip replacement or a hip resurfacing procedure. I think those are the two main operations that we have in terms of treating end-stage osteoarthritis of the hip. So in terms of those two options, if you start with hip resurfacing, that's a procedure that's been around for about 15 to 20 years worldwide, and that involves going into the hip joint and smoothing out the surfaces, the roughened surfaces of the bone, and then capping them with metal. So there's a metal socket and then a metal cap at this point. Those are the materials that are available for that procedure, and that cap goes on the top of the thigh bone, and they have very smooth metal surfaces that articulate together, and the anatomy of the hip is thought to be restored to a more normal shape with that procedure. And then there's total hip replacement, which is not terribly dissimilar from hip resurfacing in terms of the socket side of things. That's a very similar type of procedure, although it tends to be titanium on the outside, adjacent to the bone, and then lined with a durable plastic inside that socket. And then on the thigh bone side of things, we're taking the very top part of the thigh bone off, and then there's a titanium spike or stem that we then put down the thigh bone, and that typically has either a metal or ceramic ball that's attached to it that rubs against the plastic component. And that's the total hip replacement. I think that in terms of materials on the total hip replacement side, I think most of us for younger patients are are using these titanium components that are fixed to the bone. The bone grows onto that titanium, unitizes with that titanium. And then there's a ceramic ball articulating against or rubbing against a durable plastic. We think that combination probably has the longest probability in terms of longevity and least likelihood of having a complication in this patient group.
So Alex, since you do both hip resurfacing and hip replacement surgery, how do you make that decision as to which operation for the patient?
I think every surgeon is going to have a different philosophy about these two procedures and these options. Hip resurfacing is not regularly performed by many surgeons across the United States, so really takes people that have been specially trained in doing that procedure. So it may not be widely available across the United States to all patients, but we have several surgeons that work with us that do perform that procedure regularly. And they each are going to approach those patients a little bit differently. In my particular practice, patients are usually coming to me requesting that procedure. They've done their research and that's the procedure they want for various reasons. Typically, those are younger male patients. They tend to be less than 65 years of age. They tend to have relatively large anatomy. They tend to be somewhere around 5'10" or so in terms of their anatomy. They tend to be athletes. They do a lot of impact sports. They want to get back to running type of activities, either it's soccer or it's playing very aggressive basketball or some sort of, or even triathlons. Those are the types of patients that end up getting resurfacing in my practice. And then pretty much everyone else who is not coming in asking for resurfacing or isn't looking to engage in those types of activities, that level of physical activity, I'm recommending total hip replacement. But curious to hear your thoughts, Ed. I know that obviously you do a lot of hip resurfacing, so I think you could speak even more to your practice and how it might be different.
Yeah, I'd say very similar. So both operations are going to correct their problem of end-stage hip arthritis, get rid of the pain. To me, it really is about the level of impact activity they want to pursue. So in a patient who really wants to be able to run, jump, and do plyometrics or CrossFit type activities, and their bone structure and bone quality would support it, then I think resurfacing is a good option. Peter, I was wondering if you could comment on the materials you use in total hip arthroplasty and some of the pros and cons of those.
Yeah, sure. Similar to what Dr. McLawhorn said, it's titanium implants that are adjacent to the bone, so the bone can grow into those titanium implants, and that leads to very excellent long-term fixation. And then the bearing, which is basically the articulation of where your hip moves, is going to be usually ceramic ball that goes against a very hard, durable plastic liner, and that combination has been around now for almost 20 years. So we have increasing confidence in the durability of those implants. So the common parlance of, oh, your hip's going to last 20 years, I think that's dated information, prior to year 2000. And I think as our experience and confidence in our bearing in the durability of these implants has grown, we've allowed our patients to go back to more higher level and higher impact activities. So I do only total hip replacements, but also have several patients with, after education, who, in terms of impact and things like that, have returned to triathlons, to more high impact activity. And there hasn't been an association to date of increased risk of failure of total hip replacements with patients who do engage in high impact activity. So there's theoretical risk, but it seems like at this point, the durability seems to be excellent in all comers.
What would you generally tell your patient about how long an implant is going to last?
Yeah, I think when you look at large, registry studies, which means if you look at the United States or New Zealand or Australia that actually really keep track of all their patients and follow them over time, it looks like for any cause, any reason for failure, and we can, it could fracture, there's all different reasons, the ball could pop out. There's a list of things that could happen very infrequently. And when you add up all these things all together, it looks like about, 0.5% of patients will have some kind of issue per year. So at 20 years, actually, it's not that you get another hip replacement in 20 years, it's that over 90%, up to 95% of patients are actually doing well at 20 years. So it's 0.5% or even less. So at 30 years, maybe it's 85% or higher. So that's one way I think you look at longevity.
Excellent. Alex, can you comment on the use of technology in surgery to perform hip arthroplasty?
Sure. So I happen to use a variety of different technologies within hip replacement, and I think it's ultimately up to the surgeon to decide the tool with which they want to use, or the ruler with which they want to use to execute a hip replacement the best possible way they can. For me, for total hip replacement, that usually means using robotic assistance. I found that to be a very reproducible way of performing the surgery. In terms of the steps of that procedure, it involves first getting a preoperative CAT scan, which allows us to make a three-dimensional model of the patient's hip. We know ahead of time how we're going to put those implants in, the sizes of the implants we're going to put in, and the exact orientation of the implants we're going to put in. We can even do some modeling to determine where best to place them ahead of time. So we've sort of virtually done the surgery before we get in the operating room, and then we're able to execute that plan by sort of merging the virtual world with the real world during the operation. And then the robotic assistance part of things, you can, I tell patients, helps us with a few different parameters that are important for the function of the hip replacement. One is getting the socket in the perfect position that we planned based on that preoperative CAT scan. And the second is making sure leg lengths are not very different, so we can match the unaffected leg perfectly within a couple of millimeters. And then another measurement, which we call offset, but I think of as kind of soft tissue tension around the hip, can also be restored using this technology. So it's giving us feedback in real time on all these different parameters, which we know are important for hip function in terms of its stability, range of motion, and probably implant wear as well in terms of how fast that plastic is going to wear out. So if we can try to optimize all those things and then virtually and with our plan, and then execute that plan very precisely with robotics, that's the way I like to do it. But there's many different opinions out there, none of which have been shown to be the perfect way of doing hip replacement. So there's imageless navigation, and I know that Peter uses an imageless navigation product, which also works quite well in terms of restoring all those same parameters and giving him the same values as the robotics. There's pros and cons to both in terms of for the patient as well as for the surgeon and the rest of the operating team. So, and it's ultimately up to the surgeon to decide which they think is the best tool for them and their patients. There's other image-based navigation products out there as well. So many different tools available to surgeons these days to help execute the hip replacement in a way that improves the function of the hip replacement and hopefully improves its longevity.
Peter, maybe you could comment on why you've chosen to use navigation for your surgery.
Sure. Yeah. I think that was beautifully described. I think that it comes down to having a careful preoperative plan, and that comes with the imaging that we get prior to surgery, whether that's a CT scan, or I like to get these sitting and standing images, which really looks at patient-specific range of motion. So everybody sits and stands in a different way, and you can adjust positioning of your implants to basically fit that patient, that person. And then you have to execute that plan, right? So whether it's robotics, whether it's with X-ray, whether it's with computer-assisted navigation, whether it's with anatomic landmarks, you have to have a reproducible way to carry out your plan. And if you're a high-volume surgeon, I think that's been shown, like someone who does this surgery a lot, and that's more than 50 times a year, that's probably more like 100 or greater times per year. And I think that's all of us here. You have routines, and you have, that's been shown to improve, I think, your overall accuracy. I've chosen computer-assisted navigation because the accuracy is excellent, and it puts things in a position where we're talking about 1 or 2 millimeters or a couple degrees of cup positioning. So the accuracy is really fantastic, and leads to excellent outcomes that I've been pleased with how patients have done. So basically the principle is you need to have a careful plan and need to execute that plan, and however you get there is basically up to the surgeon and his experience.
Dr. McLawhorn, one of the things that I think a lot of patients are intrigued about our different surgical approaches to have their operation performed. Can you comment a little bit about the direct anterior approach?
Sure. I mean, I think I first answer this question for patients by saying there are many different ways of getting into the hip joint. And if there was a single best way of accessing the hip joint, that's the way everyone would be doing it. In terms of what me and most of my colleagues are doing, you know, it's a mixture between people that are doing this direct anterior approach that are going through the front of the hip and people that are using a posterior lateral approach where they're going through the back of the hip. In terms of how I discuss that with patients, I think the important thing for both of those approaches is that they spare one of the important muscles on the side of the hip, which is the abductor muscle. So I refer to these approaches as being abductor sparing approaches. And I think that is the single most important thing in terms of surgical approach, in my opinion. And whether or not you want to go in the front of that muscle or behind that muscle ends up being the comfort level of the surgeon and what they think is going to benefit the patient most in terms of achieving their goals. And so for me, I'm selective in terms of who I recommend for a direct anterior approach and who I might recommend for a posterior approach. I think there are different patients with different problems and different goals that are better served with one approach versus the other, and that's my practice. Some people are exclusively direct anterior surgeons and some people are exclusively posterior surgeons, and that has to do with their comfort level and their ability to achieve the surgical goals through those approaches. And so when we talk about direct anterior approach, going through the front of the hip joint, I think it's a good approach for some patients insofar as it appears to improve the hip stability. That's a somewhat controversial topic, but I think there's an emerging body of literature that would suggest that there's improved hip stability there. But you know, it has some costs too. So I tell everyone that you may have some numbness over the side of your hip that's usually temporary. So there's no free lunch here. Every surgery has the ability for a complication. And so we're oftentimes trading one complication for another if you're, or the risk of that complication. All the complications are rare, but you're trading these small risk of different complications if you choose one approach over the other.
Dr. Sculco, what are your thoughts on the matter of surgical approach?
I think that was a beautiful description. I'd say that, as I mentioned before, you know, going to a hip surgeon who's a specialist in hip replacement surgery, who does that surgery, you know, preferably hundreds of times per year, has obviously developed protocols and practices and best practice to have excellent outcomes. And that's really been shown where, you know, high volume surgeons really pick your surgeon, and oftentimes that will lead to a safe recovery and hopefully a great outcome. There are high volume surgeons at HSS who have, as Alex described, chosen to do only posterior approach, some have chosen only anterior approach, and then some who do both. I think it's really a matter of trusting your surgeon that they've gone through their steps and their protocols to have the best outcome possible. I prefer posterior approach because I think it leads, as Alex said, we don't touch the large abductor muscles on the side of the hip. You don't touch those muscles, and you're meticulous with how you open and how you close, and you're careful with your soft tissues and restore the hip anatomy. You're going to have a great outcome.
Thank you. Now moving on to kind of the recovery phase. I think a lot of patients are wondering about the recovery, what it's like. They've never had surgery like this before. Alex, can you give us a brief overview of right after the surgery, what patients can expect with their recovery?
Sure. Yeah, I think in terms of what I tell patients, in terms of overall recovery, I always start with that. I like to set the expectation that it really is going to be a year for them to forget that they had a hip replacement. So I kind of like to set the stage by saying that first. However, it's really a 6-week healing process for most patients in terms of getting back to their regular daily activities. So that's the way I counsel patients. So they're going to start by having the surgery. Potentially they can go home the same day of surgery, and they'll be walking either with a walker or a cane to start with, and then quickly just using that cane, and then usually within 2 to 3 weeks can get rid of the cane and be walking independently. And then they're gradually increasing their walking over those first 6 weeks. And that's what I really emphasize is the importance of walking in the first 6 weeks and that being the mainstay of their recovery, and not trying to rush back to the gym necessarily in those first 6 weeks, particularly not doing any lower extremity, weight exercises or, weighted squats or that sort of thing. So you do have to let your body heal for those first 6 weeks, let the wound heal, let the muscles recover from the time of surgery, let the bone and the implant start to incorporate before you start really escalating the amount of activity that you're doing. From that 6 week point to the 12-week point is really where some of those more aggressive activities are going to be reintroduced. And so, the expectation I have for my patients is that they're going to be back to, say, doubles tennis or maybe even singles tennis and golf by the 3-month mark. And that's been demonstrated in a number of different scientific studies those are good targets for patients. Those are realistic targets for patients, that they should get back to those types of activities around 3 months. In terms of impact activities, so patients that want to do running or do very aggressive skiing or plyometric types of activities or CrossFit, for me, I'm really recommending that they try to hold off on those activities till they get to the 6-month time point. What we know, for example, with hip resurfacing is that the bone density, how hard the bone is around those implants, stabilizes around 6 months and sort of returns to like a normal level, for example. In terms of that process of the bone and implants incorporating, that really becomes solid around that 6-month mark and can start to take a heavy impact and a heavy load. So those are my general guide rails for patients in the recovery process, and regardless of age. But I think that's the challenge with some of the younger patients, is they really want to get back to these high level activities as soon as possible. And we want to be there and support them to get them to that point. But we also have to understand the biology of healing and how long that takes in order for them to have a complication-free recovery.
That's a great point. Dr. Sculco, do you tell your patients similar guidelines?
Yeah, I think very similar time points. I think key is that, patients have to guide their recovery. These are general guidelines in terms of how patients recover. But we have to basically encourage them to walk as much as they can. If they feel good, they walk farther. When they feel like they no longer require the cane, it's okay to let it go. A lot of this is listening to your body and listening to your body as it recovers. We give general kind of criteria for progression. Some people recover even faster. Some people recover a couple of weeks slower. So it is a little bit of a patient-specific, guideline. I think that by doing the recovery timeline that Alex outlined, it's hard to do too much in those cases. Sometimes we get into trouble where people want to go right back to high impact activity too soon. That can lead to some, soft tissue soreness, groin pain that can set you back. So sometimes it's a matter of managing those early expectations, so we have a safe and then in the long run, actually faster overall recovery.
Great. So Dr. Sculco, would you say that the recovery from hip surgery has changed in the last several years?
Definitely. I think there's really been a transition in how we view our recovery from, let's call it maybe a sick patient model to a well patient model, where patients coming in for hip replacement, we see it as an isolated, orthopedic condition. They're otherwise, healthy. We fix that condition and then we get them out of the hospital. So patients used to stay for 2, maybe even 3 days. And we've learned over time that that's really much more than was necessary. These surgeries we can perform, in an hour and 15, hour and a half in terms of time frame, minimal blood loss with new medications that are available. Patients are able to get up the same day and basically oftentimes clear and go home the same day, as Alex nicely described. So I think our approach as surgeons to patients' recovery has come just from experience and realizing how much people can do at earlier time points, and really, getting up, getting out of the hospital, getting home, starting your walking recovery has really led to excellent outcomes without an increased risk of complications. So that's come along with just advances in anesthesia and advances with, I think, our surgical technique, with minimal blood loss, with pain management. That's really been really significant. A lot less opioid use, so less nausea, less vomiting. It's really been a whole practice change that's really not just our job, but also, how we interact with our physical therapists, anesthesiologists, and patients.
both of you have really set out great guidelines for the recovery. It seemed like the 3-month mark was kind of a milestone that the patients reach where they feel like they can transition to doing some recreational sports. One thing that I've learned in treating younger active patients is that I often have to warn them that their activity level is going to go down temporarily as they're recovering. You know, a lot of these patients are super functional on a daily basis, walking a lot, really not having too much disability. So in that recovery phase, they actually feel more limited. But of course, as they start to recover, that's going to pick up with time. Alex, I was wondering, you mentioned the return to recreational sports. Both of you have described tremendous ability of hip surgery to restore people's activities. Can you give us an idea of the breadth of activities that they can get back to, and do you place any limitations upon them?
Sure. I mean, I think by the, what I like to tell all patients is by 6 months, I really don't impose any restrictions on what they can do. I mean, I think if you're going to be more specific about it, and of course, there can always be complications related to high risk activities. Like if you were going to do something crazy like jump out of a plane, there's a risk you're going to break your bone, right? So that same sort of thing could happen after a hip replacement. So, but in terms of in terms of the activities that most patients want to do, I tell them there's no restrictions after the 6-month time period. Again, I have that sort of gradual phase into the 6-month period, so they're not doing any impact activity. They're running and you know, plyometrics and jumping types of things until that 6-month period. But after 6 months, I think we have a lot of patients that are doing a lot of high activities, whether it's triathlons or you know, aggressive skiing, all sorts of things.
Dr. Sculco, do you have any limitations for your patients, and can you give us an idea of what activities patients have been able to get back to doing?
Sure, yeah. You know, no specific limitations other than basically education that, you know, if you have, you know, contact sports and someone tackles and you have a twisting event, there's a risk for your body before you had a hip replacement, and there's a risk after you've had a hip replacement. If the hip replacement has a fracture around the implant or dislocation, of course, those are complications that may be a little bit more complicated to manage than if you didn't have a hip replacement. So I think that just patients can, I don't restrict them. It's more that there's risk with high risk activities that exist for whether, you know, you have a replacement or not. What I would say is that I agree with Alex, by 6 months, that's when the implant had full time to ingrow into the bone, the soft tissues had time to fully recover, your muscle strength, your proprioception, all the things you want for more higher level, higher impact activities, I think at that point are well established. Sometimes I'll have patients go to physical therapy for specific return to sport protocols. So you want to do tennis, that requires certain types of lateral movements that you want to make sure you can do comfortably before going back to single tennis. Skiing has certain motions that are specific to being in a squat position. So I think as we learn more, we can develop more kind of return to sport protocols and guide patients in that regard.
Yeah, I think that's important to note. You know, oftentimes I have to use the ACL reconstruction as kind of an example for patients, right? So if a patient has an ACL reconstruction, they're not back on the court or so at 3 months. That doesn't happen, right? So if that high level athlete is going to be maybe 9 months before they're back to competitive sport, and so replacing your whole joint. And so, you know, you have to kind of frame your expectations around that. And I think sometimes using these other surgeries as an example, you know, that they may understand, and maybe had a friend that went through something like that. It helps them better understand what our expectations are for them getting back to sport. We know they're going to get there, but having a realistic timeline of when they're going to get there is important to realize.
I would just mention that, you know, our guidance for patients has really evolved over the last 10 years. So if you sampled some, you know, very high volume hip surgeons for ability to run, probably more than 75% of them were educating patients not to do that. I think that it's really come with another decade worth of knowledge in the performance of our implants that our recommendations have slowly but surely evolved and will continue to evolve as we get more and more data, you know, over time. So, if a surgeon treating you recommends against high impact activity, it doesn't mean necessarily that that's a wrong recommendation. I think that we're still dealing with situations where we don't have, the best long-term data yet. But let's say, and it is an evolving recommendation, I think, that is changing over time as we get more experience and more knowledge.
That's a great point. I think with our knowledge and information from the current generation of implants and materials, we're all becoming more confident about the performance of these joints, especially in the younger active patient. So last question to pose to both of you. Many of these young active patients have to balance the decision for surgery with the potential need for revision. What would you tell these patients about the concern of revision in their future?
Sure. I think that there's a couple of different things. One goes back to what we talked about earlier in terms of quality of life, and the fact that having good quality of life now in the present time is much more valuable than something that's 10 or 15 years from now. So I think that's the way I approach that conversation with patients. There is a likelihood that they may have a revision. When we looked at younger patients that performed to higher levels of activity, there maybe was a slightly decreased risk of longevity in some of those implants. Not hugely different than people that were sedentary, but there is probably a small difference. So maybe 10, 15 years from now, there might be some small percentage of patients that do need to undergo revision because of the activities that they engaged in. But again, those 10, 15 years of good quality of life, doing the things they really want to do, we know are very valuable to patients. In terms of revisions, I think that that's another area where we've improved a lot in terms of our technology, our ability to perform those complex surgeries. And I know that Peter has deep experience in this as well. Just being able to now use modern day technology that we have available for revisions and getting patients back to actually decent level of function even after a complex revision surgery. That's still possible. So I tell patients not to worry about something that is probably a rare event, and it's going to be more than likely decades from now, if ever.
Yeah, you just add that. I think that a lot of the materials that we use today, I think, have really addressed some of the most common reasons for failure from 20 years ago. So, for example, the plastic we've talked about, we just talked a lot about how much better the material properties are of the plastics, and we don't really, the wear properties, which used to be 1 millimeter per year of wearing out of this plastic insert we put in, is now less than 0.1 millimeters. So there's been a revolution, it really revolutionized the materials. We used to cement in our implants, and now they're uncemented, so they're biologically bound to bone. So two of the most common sources of why our implants didn't survive into several decades have been addressed with improvement of our technology. So that's made an incredible difference. I think also it's in a difference where the types of revisions that we used to have, where the bone used to degrade because of all this wear of the materials, the cement used to break, that would cause issues with the bone. We don't see those significant changes with our modern day implants. So the types of revisions, if they were to be required, oftentimes are much simpler and more straightforward than they were when implants used to fail 20 years ago. So I think that those are reasons to be encouraged as hip surgeons today, and why I think we're more willing to offer this surgery to younger, more active patients.
Yeah, I agree. I mean, I think, all of us are kind of entering this age or within this age where, we're in the age group that we're talking about. So, we have kids that are playing sports and we want to play sports with them. We have all these activities that we want to do and expectations for ourselves. And if I had a hip condition that needed to have a replacement, I would elect to have one, so that I could do all those things for myself and all those things with my family. And, I think that's what I tell my patients that are of similar age to me that have these problems.
Terrific. Well, I think this has been a really informative discussion about the management of hip arthritis in the younger active patient, with a discussion we had ranging from exercise with a chronic arthritic condition, non-operative treatments, surgical options for these patients. You guys gave us guidelines about the recovery process talked about the tremendous improvement in the quality of life that can be achieved with the surgical intervention, and really a return to an incredible range of activities. So I want to thank Dr. Peter Sculco, Dr. Alex McLawhorn for sharing their expertise on this topic.
Great. And thank you, Dr. Su. Thanks for being a great moderator for this. This is great.